Right, good afternoon and welcome to what is the seventh of our Key Opinion Leader webinars. I'd like to welcome first of all Mr. Sashin Ahuja. Thank you to him for speaking today. There he is. What we're going to do first of all is just go through some housekeeping rules, a bit of information about the webinars and how you can communicate with us as always. So we have a Q&A function. So if you can channel all the questions through there, please. We will try and get through as many as we possibly can. But obviously, as you can understand, there's a lot of people on this webinar, so we can't always answer all of those questions. We will try and get them in as we go through in a timely fashion, but then there will be some at the end as well. So do stay around for those. There will also be a follow-up with a certificate. This normally should go out tomorrow at about 10 o'clock. If you have any problems and you haven't received it by the end of the week, by all means, just give us a call on eventsne@ossur.com. Also be aware that, that when the file comes through, you can save it as a PDF just by clicking Save As PDF, because we've had a few inquiries about that. There will be a questionnaire as well. It's really helpful for us just to know how and what subjects you'd like to cover as we go forward. And if you'd like to see any of the previous webinars, if you go on YouTube and look at Össur Academy, all of our previous webinars are on there, also as well as some of the content from other regions within Össur. What I'd like to do now is just give you some information about Mr. Ahuja and a bit of information about his life. And so he's a consultant orthopaedic spinal surgeon at Cardiff and Vale University Health Board, where he's worked since 2003. He's currently practicing at the Welsh Centre for Spinal Surgery and Trauma, University Hospital of Wales, University Hospital Llandoch, and Noah's Ark Children's Hospital for Wales, as well as working privately at Cardiff Spire. His practice covers a full spectrum of spinal disorders, including paediatric deformity. He's also really actively involved in education, convening cadaveric and interactive courses for senior trainees and consultants. He's the lead for the Centre's BOA and OA Spine Recognised Fellowship Programme, as well as publishing regularly in peer-reviewed journals and authored book chapters. He's the current British Association of Spine Surgeons President, AO Spine UK Council Chair, and co-chair for the Spine Orthopaedic Data Evaluation Panel. And he's also an expert advisor to NICE and also MHRA as well. So just remains for me to pass over to Mr. Ahuja, and he can start his presentation. Please remember, questions through the Q&A. Thank you very much.
Right. Good afternoon, everybody. Thanks, Stuart and Giles, for the kind introduction and the invite. Thank you, everybody, for joining us on a lovely sunny afternoon, especially here in Wales. It's nice and sunny. I suppose you might hear a few birds tweet from the window, maybe. So I'm going to be talking about management of spinal trauma. Now, it's a very, very vast topic. I don't think I could do justice to it by just one talk. So I'll just cover a few basic things. And I like to keep it interactive, so please keep the questions flowing. Keep Giles busy and his team busy so that we can keep interacting with you. Giles, what's going on? Okay, firstly, no disclosures for me, please, and I'm not being remunerated for this webinar. It's not a message to Stuart or Össur. It's just for everybody that these are my opinions, what I am putting forth. These are my cases that I have dealt with. So can I just run through the first poll, please, Giles?
So again, as we normally do, but it's really useful for the speakers to find out your role. So what is your role? Are you a consultant spinal surgeon, an other type of consultant, a doctor, registrar, a physiotherapist, a nurse, an orthotist, a plaster technician, or other? So we have, I'll just leave it up for a little bit longer. We've got just over 70% of people have responded so far. Brilliant. So I'll just stop it there. We've got to 80% there, and then share that. So you can see that we have 1% consultant, spinal consultant, 1% other consultant, 2% doctor or registrar, 64% physios, 1% nurse, 23% orthotists, 1% plus technicians, and 7% other.
Okay, thanks, Giles. So that gives us an idea of who we're interacting with, and it'll be good to have those questions accordingly. Can we have the second poll as well, please?
Yeah, so this is more about your experience of spinal management. So do you have very little experience of spinal management, some experience, moderate level of experience, good level of experience, or a high level of experience? And again, because Mr. Ahuja will be using case studies, it just helps him to know a level of depth in terms of how deep he needs to go into those. So nearly at 80%. Brilliant. And I'll just stop it there and share those results. So it's come out in the middle. So 28% have moderate level of experience. Again, 27 with some level of experience, and then 21 with a good level of experience. So a good spread.
Yeah, it's a nice bell curve in the middle there. So yeah, it gives us an idea of experience. So my talk, I'll cover a little bit of pathology, a little bit of boring anatomy, but anatomy being very important as to what happens. Take you through the concept of instability and instability, instability and stability of the spine, some management options, and then cases to highlight all the points that we've discussed earlier. So I think this is the basic foundation of the spine. So this is the functional spinal unit. So as you can see, it's made up of the vertebra above, the vertebra below, the disc in between. So any segment, right from occiput to down, C1, 2, C2, 3, right down to L5S1, it's just one vertebra lining up with the next one, and the articulations that go with it, with the disc in between, the canal where the spinal cord sits, and the posterior elements, the spinous process, the transverse process, and the joint at the back, the facet joints, which form the articulations in the spine. So you got the disc anterior, and you got the facet joints in the back, which hold everything together apart from the ligament and the muscles. So the ligaments that we have are mainly the anterior longitudinal ligament in front of the vertebral body. As you can see there, there's the posterior longitudinal ligament, which is behind the vertebral body. And behind the posterior longitudinal ligament is where the spinal cord sits. You got the ligamentum flavum, which is in between the laminae. You got the interspinous and the supraspinous ligaments, which are in between the spinous processes. So these have got very important roles to play because they're check reins. Because as the spinal segment is loaded, these check reins help control things, help preventing the excessive force to cause damage to the spinal column, may it be to the soft tissues, which are the ligaments and the muscles, or to the bone itself. So as another way to show you the ligaments, so the anterior longitudinal ligament, as you can see in the front of the vertebral bodies, the posterior longitudinal ligament. So if I just, so this rhomboid shaped structure is the posterior longitudinal ligament, which is gelling with the annulus. So this is the disc, and the ligament gels into the annulus and supplements it. But behind the vertebral body is just a thin strip of ligament. So compared to the anterior ligament, the posterior ligament is relatively maybe smaller in width-wise. So we all know how the spinal column looks, and that's not what I have put this for. We all know what the parts of the spinal column are, and again, that's not what this is for. What this is trying to tell us is what is the normal alignment of the spine. So the cervical spine is in lordosis, the thoracic spine is in kyphosis, the lumbar spine is in lordosis, and the sacral segment is in kyphosis. We all know that. We all know that. So it's not something new. But the problem is the junction between the lordotic cervical spine and the kyphotic thoracic spine. So, and the other thing is, in the thoracic segments, you can see the articulation for the ribs. The ribs are splint the thoracic vertebrae, whereas the neck has got an easy movement, excessive movement, which can cause that junction between the lower cervical and the upper thoracic levels to fail. Same way, if I go up even further between the skull and the upper cervical vertebrae, that's why C1 and C2 seem to be the most commonly affected vertebral fractures that we can see. And they are slightly different. That's why we divide the cervical spine fractures into subaxial and supraaxial. So below C2, because then they're the normal cervical vertebrae, they're fairly similar, whereas C1 and C2 are slightly different to the rest of the cervical, rest of the vertebrae. In the thoracic spine, you've got the kyphosis. And as I said, the thoracic segments are partly splintered because of the ribs. But at the junction between the thoracic and the lumbar spine, at that area, virtually between T10 and L2, which is the 10th thoracic and the second lumbar, the spinal column is relatively straight. So it's between the kyphosis and the lordosis. So that segment in the middle is the straight segment, which can take a lot of load. And you can imagine the transition from an area which is splintered with the ribs to an area of the lumbar spine, which is quite mobile, takes a lot of brunt, and fractures are quite common in the thoracolumbar region because of the alignment, the way our spine is aligned. So, Charles, can you put the next poll up, please?
So the next poll is, do you understand the concept of stable and unstable? It's just a yes and a no. Okay, so we've got 60% of people have voted so far. It's going up very rapidly. We're very nearly at 80%. Leave it on a few more seconds. Pretty conclusive, this one so far. So as you can see, it's 85% have said yes, they understand the concept of stable, and 15% have said no.
That's great. That's great. And I'm really pleased to see that. And I say this statement all the time. When a patient comes into the hospital, right, everybody, doctors, nurses, physios, orthotists, even the porter would like to know if this fracture is stable or unstable, how that patient is transferred for the x-ray, how that patient is taken to for CT, for MR, right? That's how important the full thing is about stability and instability, right? So as long as you understand that, so it looks like most of us are aware of it, which is good. So it's based on the definition from White and Punjabi. No, it's a big, long-winded paragraph there. Basically, it's trying to maintain the alignment of the spine under physiological load. And the moment the structure of the spine cannot bear weight under physiological load, right, it can cause problems. So then the function of the spine is affected. So you could have neurological problems because of the loss of alignment. It can cause pressure on the spinal cord or on the nerve, giving us to neurological issues, or it can cause deformity. So in that segment, so, you know, as I was showing you the cervical lordosis, the thoracic kyphosis, the lumbar lordosis, so it can cause loss of alignment and deformation. And along with that comes, unfortunately, the commonest symptom that we all treat, which is pain, and it could be intractable pain. So these are the things that we look out for. And that's how stability and instability is defined in a clinical sense. But it's not just, so it has mechanical issues to it, which could be deformity, and the neurological issues causing neurological problems, and symptom being the pain factor, which is a significant problem. Now, if you look radiologically, how do you decide based on the anatomy whether a fracture is stable or unstable? And some of you may know about this concept, so I'll just bring that up. So this is splitting up the spinal column into three separate segments. So you've got the anterior column, which has got the anterior part of the vertebral body, along with the disc that forms the anterior column, which is basically extending from the anterior longitudinal ligament to the middle of the vertebral body, or virtually to the 2/3 roughly. This column, which is the posterior third or posterior half of the vertebral body, extending to the posterior longitudinal ligament, this blue line that you see, is the middle column. And everything behind that, including the spinal cord and the pedicles and everything, forms the posterior column. So if two of these columns are affected, one would think that that is an unstable injury, and that's an unstable fracture. And that's where it becomes, so you start, if you look at a plain x-ray and you see both the columns are affected, or a CT or an MRI scan, you go, that's unstable. But there's a slight downfall to that. And that is one of the reasons why we don't use this concept anymore. I'm purposely putting this forward because quite a few people believe in this theory and believe in this concept, because a lot of classifications are based on this theoretical model. And I'll give an example later on in the cases to explain why this doesn't work. So the simpler one is this, right? So you divide the spinal column into anterior and posterior, anterior being everything in front of the posterior longitudinal ligament. So I've made that PLL red. So everything in front of that red line where the posterior longitudinal ligament is anterior column. Everything behind becomes the posterior column. So if both the columns are affected, that fracture is unstable, right? It's as simple as that. So you can get that information based on your clinical assessment when you log roll the patient and you feel along the spine and you feel a gap between the spinous processes, which is more than the level above and below. You'd go, very likely there is a ligamentous injury. You may feel a big dip there. You may feel a hematoma, all those sort of things, right? And on an X-ray or a CT, you will find that the anterior vertebral body height has collapsed down because the commonest vector is a flexion vector, which causes a compression injury. You could do an MRI scan to look at the ligaments at the back, and that will pick that up as well. So that will tell you that there is an anterior and a posterior column injury, which would make the fracture unstable. So it makes it a little bit easier to understand and comprehend what is actually going on. And that is how we can figure out if the fracture is stable or unstable, and then you can treat them appropriately. So there are different classification systems that are used. I'm not going to go into those because there are too many and they're quite confusing. But the classification systems help us understand if the fracture is stable or not. It helps us understand what was the mechanism of injury, because that mechanism of injury is important to understand what has happened. How has that spinal column failed and why has it failed? So why is the bone fractured? Why is the ligament disrupted? So it gives you an idea of what is happening. So if you're in a car and you are accelerating and you have an impact and that sudden deceleration pushes you forward, you can imagine the vector is that forward flexion vector, which causes the vertebra to collapse down. And at the same time, at the back, it'll cause things to open up, causing damage to the ligament at the back. So you can see what that is doing. So if you see the X-rays, it gives you an idea what is happening, all right? Classification also helps you understand the pathoanatomy. So how is that anatomy being affected? What has happened? Also for communication and research, so if we say X classification, X type, then when you're speaking to somebody, even without showing them the images, they have an idea, have a perception of what the fracture may look like. And from a research point of view as well, it becomes very important. So one of the classification systems that we use is the AO classification. AO is one of the common trauma classifications that we use generally in orthopedics and most long bone fractures or even for facial-maxillary. So it's quite a comprehensive system. I'm not trying to sell anything, but just to explain, it's very simplistically, A-type fracture is a compression injury. So if I am like this and I have a flexion vector, so that flexion vector is going to cause a compression impact anteriorly onto the vertebral body. So for example, you can see on this X-ray, so you can see the vertebrae, right? Can you see this vertebra? This is slightly crunched down, and that has happened because of the flexion vector, right? And that has caused that vertebra to collapse down and sustain an injury, and it fractures. Imagine if that vector went on and on and on, that vertebra would collapse more. And along with that, we may also see disruption of the ligament in between the spinous processes, which you can visualize much better lower down here. I hope you can see when I'm pointing it out with the cursor. So that's the compression injury. So you can get a compression fracture, which is one of the commonest fractures that we tend to see. Or you can get a distraction injury. So like you got a compression vector in the front anteriorly, you can get a distraction vector posteriorly. So it's like, which disrupts the tension band. And what that can do is can disrupt the ligament. So now if you look at this X-ray and you may look at that and go, overall, that doesn't look too bad. But if you look at the alignment, look at that disc, look at that disc, look at this disc here. The anterior part of the disc in the front is wedging down, it's closing down, and the back part is opening up. And that should give you a clue of something that's going on at the back, maybe. So you can see the spinous processes. The gap between the spinous processes is good. Look at the gap between those two spinous processes. It's increased quite a lot, right? So that is because of that flexion vector. So the ligaments in the back have disrupted and those spinous processes have opened up because the ligament has completely gone. And if that injury vector carried on, you can just about see what's happening to the facet joint. So look at the facet joints there. So the facet joints are like tiles on a roof. They're holding fine. But as the vector comes up, that tile can slip. And as the tile slips forward, which at this level where the injury is, you can see it's just starting to hinge. It can go forwards. It can take the spinal cord with it, causing significant damage and injury to the spinal cord. So this is a slightly more progressive injury compared to the A-type fracture or the compression fracture that I was showing you. Now, this is even worse now. Not only do I have compression, right, and the distraction injury in the back, we also have an element of rotation. So what is that doing? That is leading to the vertebra slipping forward. So as you can see, that's the second vertebra, third, fourth vertebra of the cervical spine. So between 4 and 5, can you see there's a slip? So what's happened is that vertebra is virtually dislocating, right? So those tiles on the roof that I was talking to you about, one tile has definitely gone forwards because that is displaced by at least nearly about 50%, right? So it can go more and it could have gone even further. Maybe the other joint is hinging or it's not dislocated completely yet, right? But that is something that can cause problems. So that can lead to spinal cord injury, right? So you can see the higher the injury, higher the force with compression associated with the distraction, associated with rotation, can cause significant damage to the spinal column, right? And cause damage to the spinal cord. So you can see the previous one that I was showing you with the dislocation. Look at the spinal cord. The spinal cord is completely tented over, right? Look at the signal in the spinal cord. That's how the normal spinal cord would look. If you see higher up or lower down in the thoracic, it looks nice and grayish dark. Look at all these white areas, right? All these white areas is the edema or the swelling in the spinal cord. So say, for example, if I injure my ankle and I twist my ankle and I've got an ankle sprain, you do an MRI and that will show a lot of fluid, a lot of white areas. And you can see all the white areas that all this signal change that we see in the paraspinal muscles, right? Look at the amount of disruption. So that injury can cause a direct impact to the spinal cord because of the hit to it, because of the local deformity and the energy, right, that the spinal cord had to bear because the spinal column was protecting it. Once the spinal column fails, the spinal cord fails as well, unfortunately. So that's what we want to protect, right? So that is how you can get a primary injury that happens at the time of the impact. And unfortunately, whatever happens at the time of the impact, we cannot reverse, right? There are lots of studies ongoing trying to regenerate the spinal cord, do a lot of different things, stem cells, you name it. And there's lots of research ongoing. But unfortunately, we haven't hit the holy grail yet, right? And the injury is the injury. What happens at the time, and not much recovers. And you can see in this specific patient, you can see the amount of damage it's done to the spinal cord. Although the injury is at the level of C4 and C5, the damage extends right up to C2 and lower down to nearly C7. So you can see the extent. So virtually the full spinal cord in the cervical segment is affected. Along with that, you can get secondary injuries, right? So the secondary injury is how the spinal cord then reacts. So there could be some biomechanical responses, there could be some cellular responses, which can cause more problems. And that is why what we tend to do is try to limit that, right? So most treatment that we offer is to limit that secondary injury because we cannot change the primary injury, right? And how much ever you try, and I'm sure you all know about various presentations of patients with paraplegia or quadriplegia because of trauma. Not many, if they're complete, recover, right? Very few. I wish there were more, and that's what we as spinal surgeons and basic scientists are fighting and trying to get some sort of a cure for this so that at least we can improve some function, give some neurological improvement for these patients. So the spinal cord injury could be complete, right? So if it is at the level of your thoracolumbar junction, you could have paraplegia with no function in the legs, no sensations in the legs, loss of bladder bowel function. If it is higher up, unfortunately, you can get quadriplegia, quadriparesis. So it could be a complete injury or an incomplete injury. Or you could be lucky, right? You could have a significant impact and not cause any damage, right? How lucky can you be? And hope everybody is like that. But unfortunately, that's not the case that we see. And I'll show you some cases later on, right? But this is the spectrum that we come across. So I'll give you a good example of what I was saying of the injury, the impact. Now, gone are the days where, an X-ray of the cervical spine was, lateral cervical spine X-ray was part of the primary survey. When patient comes into A&E, nowadays they get a CT. They get a CT head, CT whole spine, right? They get a CT chest up the pelvis. And if you look at this X-ray, this CT, this is an elderly lady who presented to us a few years ago. And you can see that she's quite degenerate. Look at the discs, right? Significantly degenerate, ossified formation. But if you look at all that, that alignment doesn't look too bad. And you may go, that doesn't look bad at all. That looks pretty good, right? And one may look at it and go, that's good. But there are some subtle signs here. Even on this just one film. Okay, I'm sorry, I'm giving you a snapshot. I'm just showing you one CT cut. There are multiple. But if you look here, she does have a significant soft tissue swelling in front of the vertebra, right? So it just started ringing some alarm bells. So this lady's had a fall, she's hit her head, and she's complaining of neck pain. You look at the CT and you go, nothing much, it looks pretty good. But when you do an X-ray on her, you see this. And as I was talking to you about before, look, there's a displacement. Second vertebra, third vertebra, fourth vertebra, fifth vertebra. Between 5 and 6, there is displacement. Look at the gap between the fifth and the sixth spinous processes. Massive gap, right? So that definitely suggests that there is disruption of the interspinous ligament. It suggests there is something going on with the facet joint. It suggests there is disruption and displacement of the vertebra one on top of the other. So that is a grossly unstable injury, which on the CT looks very benign, right? So you've got to assess the patient. You've got to look at subtle signs which give you a clue what this is, whether this is a stable or an unstable injury. On the other hand, you may look at something like this and you go, yes, this is bad, right? And you can see how the spinal cord is deformed at the level of the injury. So again, that's the second vertebra. Third, you might say, well, I don't count 1 because 1 is relatively small. 2, 3, 4, 5, and 6. So you can see the displacement between C5 and C6. There is a subluxation. The spinal cord is tented over that. Now, this is how it is when the patients come to us and we've done a scan. But if you look at it, this is perhaps what happened, right? And that image, I suppose, gives you a better understanding of what is actually happening there. All the ligaments are disrupted at the back, right? And you can see the disc is disrupted, right? And how much displacement. The posterior longitudinal ligament is disrupted. The supraspinous ligament is disrupted. The interspinous ligaments are disrupted. The facet joint alignment is disrupted, right? And imagine that is how it is in this resting position. Imagine when the extreme flexion where it would have been, right? When the chin was virtually touching the chest, how much damage it would have done to the spinal cord at that moment. So please remember that. So what we are seeing is resting images. We're not seeing the dynamic image or real-time image when that injury happened and how the spinal column gradually, took the strain and failed and tried to protect the spinal column, or the spinal cord, I mean, and the spinal cord also failed eventually because of the impact on it. So when these patients come to us, like any patient with polytrauma or any injury, they go through the ATLS protocol. So most of these patients will come to us if they've got suspected spinal cord injury. They will present to us on a spinal board to immobilize the spine. They will have bolsters on the side of the head, and they'll have strapping, and they will have a hard collar. So the neck and head is triply immobilized. So you've got a hard collar, you've got bolsters on the side, and straps on the forehead at the level of the chin, just to immobilize the head and neck, right? But please don't forget, these patients can have high velocity, maybe because of a high velocity injury, and they could have other injuries as well. So as per the ATLS protocols, of course, you've got to protect the important things, right? You've got to make sure the airway is good. You've got to make sure that the breathing is good, the circulation is good. These are vital things that we need to take care of. Yes, the patient may have a spinal cord injury as well, or a spinal column injury as well. But those are the issues that we need to take care of first. Okay, we don't forget about the spine. So that's why rather than just say ABC, which is airway, breathing, circulation, you have the cervical spine protected as well. So you triply immobilized it. And we got the spinal board and the triple immobilization, as I mentioned. You do a full neurological assessment. You do a full assessment of the patient, right, from their general signs, different systems you've got to look at, including the neurological system. And don't forget, you're examining mainly the patient on the front because that's how they're lying. Don't forget to log roll them, right, and assess them from the back as well, because you could pick up some vital things when you log roll them. So the initial management, the priority is to protect the spinal column and the spinal cord. It is secondary to figure out what the main diagnosis is. Get the airway sorted out, get the breathing sorted out, get the vital parameters taken care of. Once everything is fine and the patient is physiologically stable, then we can start looking at what do we do with regards to spine, right? Now, you don't need to keep the patient on a spinal board for too long. Please remember that. Within an hour or two, take the spinal board off. They're lying on a bed, they're lying flat, they're not moving around, they're relatively immobilized. You're fine with that. You don't need to strap them down completely for all, because with the spinal board, if they've got a spinal column, spinal cord injury, and if they've got sensory issues, they may be insensate. And because of that insensate nature, they can develop pressure sores quite quickly. Yeah. So most of you, I see that you're physiotherapists, you know this, and I know there is an update on this. It's not called Asia anymore, it's called Insignia or something like that. But this is what we tend to use all the time to monitor the motor function, monitor the sensory function. So to look at all proper neurological assessment so that we can see what is going on. And we as a tertiary service prefer to have that input from our referring hospitals, whoever's examined the patient, to give us an idea, what is the sensory level, what is the motor level, right? Whether they've got their bladders working or not, right? What's their PR like, right? These are important things because that helps us decide whether it's a complete cord injury or an incomplete cord injury. Then we can start making a decision as to how we're going to treat that specific individual. Yes, they need to come to a tertiary center, but the timing, sometimes beds are issues, and we know that. It's not utopic everywhere. Sometimes we don't get beds straight away. You may ask for a patient to come across, but then at least you can highlight this patient needs to come straight away, or this patient can wait for a little while and come over because we're going to deal with them in a different fashion. But they need to be referred to the tertiary center. That's what happens here. So treatment, usually, like anything, you treat them conservatively or operatively. Conservative treatment usually would be bed rest, traction, bracing. Bed rest is utilized. Even still, you'll be surprised to hear. Yeah, because sometimes patients have got polytrauma, right? They've got multiple injuries. So, and they can't be mobilized in any case. So you go, and some of those fractures, some patients have got 2, 3, 4 vertebral body level fractures, which you can fix. I'm not saying you can't fix, but if in the given scheme of things, if the patient's going to be immobilized because they've got multiple other injuries, then you might as well treat them non-operatively, and then you put them in bed rest. So conservative treatment mainly for patients with stable fractures, some polytrauma patients, patients who are unfit for surgery, and osteoporotic fractures, which is a relative indication for conservative treatment, because osteoporotic fractures should be treated surgically as well. I'm not saying not all of them, but it's a relative indication, and I'll show you a case later on. So the common things that we use, so mainly conservative treatment is bracing. All right, so you all know about the braces. I don't need to go into details of that. And so you could have different type of orthosis, so braces, halos, halos with pins, or pinless halos. And like any treatment, there are complications. It's not something that is devoid of risks. All right, anything you do has a risk. You cross the road, there is a risk. right? You cross the road on the motorway, the risk is different to crossing the road outside your house. So it's, you weigh up the risks and benefits and you decide what's best for that individual and you treat them appropriately. But if you treat somebody with a brace, you got to monitor how they're coping with the brace. They could get pressure sores, right? They could have, if you're treating them with bed rest, then patients can have respiratory problems. They can have problems because of prolonged immobilization. So they got to be in the right place. They got to be nursed appropriately. If you're using a halo, you can get pin tract infections. And sometimes when you're treating patients with a brace, not sometimes, you have to monitor it. You've got to look after it. So, simple analogy, Colles fractures, distal radial fractures, which are treated in a plaster. We don't put a plaster on and say, come back in 6 weeks and we take the plaster off. We get the patients back a week, maybe 2 weeks, repeat an x-ray, look at the alignment, right? And that's exactly the same thing you need to do with this. You need to have serial follow-ups, serial x-rays to make sure the alignment is maintained. And if if you're losing alignment, it is suggesting this fracture is unstable and needs stabilization. So you can sometimes get progressive deformity. So that is something that you need to look out for. And here's an example of halo. And you can see what's happening here. This is a true story, halo pin. So you can see the pins. The pins normally should only be in the outer cortex. So there are two tables of the skull. So the outer table, not to penetrate the inner table. This was being tightened by the patient's wife. And this guy presented to us when he started having fits because he developed a brain abscess. And this is true, I'm not making this up. So these are not, okay, we may say that a halo is used for conservative treatment, but it has got its own risks. So be mindful of that, please. So going on, I'm a surgeon. So as you can see, I'm going to be talking more about surgical management. But I would say here very straight, like quite a lot of our patients get treated non-operatively in a brace. I know showing you those x-rays and how non-operative, how we treated them non-operatively may not look very sexy compared to all the metal work I'll show you in a minute. But there is a huge room for conservative treatment for the right patient, for the right indication, right? So indications for operative treatment would be unstable fractures, patients who've got any neurological problems or progressive neurological problems, polytrauma patients, again, as I said before, you want to get them up, you want to get them going, but sometimes surgery may not be amenable. They may have a complex acetabular fracture. They may have lower, calcaneal fractures, and that can't be fixed. So all those sort of things. And then you got to work with your orthopedic colleagues and your trauma colleagues and then decide what's best for the patient. You go, fine, in this situation, we could treat this patient operatively or non-operatively, and you can plan that. Patients who've got progressive deformity or failed conservative treatment would be candidates for surgery. So I'll show you an example. Sorry for the blurry view on the CT. This is a very old film, not because it's blurry, because I think I had some shakes when I took this picture with my camera. I didn't have smartphones in that era at the time. Anyway, so this is a young kid who's about 16, and he's got a pec fracture. And as you can see, that's the pec fracture there. And, obvious thing, pec fractures usually are treated non-operatively, especially in the elderly. In our setup, we sometimes don't even consider putting them in a hard orthosis. We just give them a soft collar for comfort. But in this young kid, we were treating him with a halo. So he was in a halo for nearly 6 weeks. This is his CT scan at 6 weeks. This is true story. So this is what it looked like. He wasn't healing. We couldn't leave a 16-year-old with a non-united pec fracture. So went ahead and operated on him. And he had these screw fixation, anterior screw fixation approaching from the front of the neck. And you can see, I'm not making this up, this is 3 months. And within 3 months, he's a young guy. He's got good healing potential. And look, all the fracture needed was stability, and the biology took care of the rest, right? Once the fracture was adequately stabilized, it healed up beautifully. And he regained full range of movement. This was about 2002 or something like that, right? It's that far back. Here's another example. Gentleman in his mid-20s who had a road traffic accident who presented to us. And you can see on the X-ray, I agree it's a blurry film, but this is his X-ray which was done when he came into A&E, a lateral shoot through X-ray, and you can see the C5 vertebra. Can you see the fracture going through that? So there is a fracture of the C5 vertebra, right? And one important thing I would like to say, now most of us would go thinking like, oh, okay, he mentioned earlier that anterior and posterior column injury together makes the fracture unstable, right? Can I just say, for a minute, in the cervical spine, you can forget about that stability and instability principles that I talked about. Honest. Any fracture in the cervical spine, until proven otherwise, is unstable. So those concepts about 2-column, 3-column are mainly for thoracolumbar injuries, right? But in the cervical spine, if you see a fracture, it is unstable until proven otherwise. Yeah. And if you work on that pretext, you're absolutely fine. So that's the CT scan, and you can see the fracture in the vertebra, right? And you can see a little bit of retrosthesis. The vertebra is migrated backwards. So can I put a poll there, please?
Yeah, so do you think that this case should be classified as stable or classified as unstable? So it's stable, unstable, not sure.
I think I've given the answer away, haven't I?
So, although people are thinking about this one a little bit more, so we're up to about 65% of people have answered. I'll leave it up for another few seconds. There we go. So we're up to 70% there, and I'll just share those. So you can see that 9% said stable, 79% said unstable, and 12% were unsure.
And with due respect to the ones who said stable and unsure, I would repeat, please, any fracture in the cervical spine should be considered unstable, please. Yeah. Okay. So you can, again, some blurry films, but you can see the C5 vertebra. It's quite badly crushed. And I can tell you now, this is the C6 vertebra. He's got a longitudinal crack going through it. Now, if I go back to the images, he's got the C5 fracture. He's got a crack going through C6. This potentially may not be very good. We could stabilize it at the back, or we may have to do a vertebrectomy and fix from there to there. So there are different options that we may have to consider. So I sat down and had a chat with this young guy, and I said, what should we do? We can treat you non-operatively, we could treat you operatively. And I went through the options, exactly the options. I said, I could do this, I could do that. And we went through everything. And it was great to engage with him and talk to him. And he was very willing to understand things and was happy to partake in this discussion. And he turned around and said, I am not interested in surgery, right? Can I not have surgery? Can we try something else? So we treated him with a halo. So he had a halo on for nearly 3 months. And I'll be honest, by the 3 months, he was desperate to get the halo off, right? Imagine walking around with a cage for 3 months. It's a long duration, but it did the job. It did the job. And you can see at 3 months, that is his flexion in X-ray, and that is his extension X-ray. The spinal alignment looks good. There is no instability, and he was absolutely fine, right? And he had physio after, and he was discharged, and he's gone back to doing everything. He could have ended up having fixation done with fusion, which we didn't have to. So the fracture healed up well, and I think it was the correct call from both parties that this was the right thing to do for him, and it worked well. On the contrary, here you have another patient who's got a similar type injury. So C2, C3, C4, C5, again, C5 body fracture. The CT scans are a little bit better here. So you can see the C5 is completely disrupted. C6, there is a fracture going through the C6, right? Again, there are 2 levels which are affected. And a similar situation, sat down, spoke to this guy, and he goes, I'm a manual worker. I would like to get on and get things done. I want this stabilized. So fortunately, we only ended up doing a single level vertebrectomy. I know you can't see the cage, but you can see the markers, which will tell you where the cage is and the plate. And this is him 6 months post-op he's regained good function with regards flexion and extension. This is another injury. This is a rugby injury, hyperflexion injury, as I was talking about, flexion, right? And you can see the parasagittal cuts on the right side. So you can see the tiles on the roof, See how that tile is just wanting to, so it's not like this, it's just there wanting to drop over. And you can see the tile on the roof on the other side, which is dropped over completely. And that has caused the vertebra to displace. And I know this is not an MRI, but you can see where the spinal cord is, how badly that's been affected. So not only has the spinal column failed, but the spinal cord has been significantly damaged. And this patient, unfortunately, had complete spinal cord injury. So this would be an emergency. You would want to correct it as quickly as you can. So you may put them on a traction, or you may, if it reduces with traction awake, that's great. If not, then you would operate and do an open reduction, because the disc can be sitting on the spinal cord and you can't do a closed reduction asleep. So that's what this patient had. He had surgery from an anterior approach. The vertebra was realigned, a cage there, and a plate on top. This is a 12-month post-op X-ray, and you can see the segment is starting to knit, or it's knitted together. So that's pretty solid, right? Unfortunately, it didn't recover neurology much because of the damage that happened at the time of the injury. Here's another fracture. This is a gentleman who was in his late 30s, early 40s, had a road traffic accident, comes in with this injury. Again, like, one would ask, is this stable, unstable, right? And if you go with the 3-column concept, this is involving the anterior and the middle column. So this is unstable from that point of view. So if you remember, I said half or 2/3 of the vertebra and the posterior column, which is the posterior half, up to the posterior longitudinal ligament, both are affected. This and that classification would be unstable. But with the 2-column concept, this potentially is stable till we know what's happening in the posterior ligaments, and the posterior ligaments were intact in this. So this, according to me, is a stable injury. So burst fractures were the downfall of the 3-column theory. So this patient we treated non-operatively with a brace, and this is how he's been treated. And this is a CT scan at 3 months, and you can see the fracture knitting together, and you can see bony bridging there as well. Yeah. So that's another example. There's another young guy who was involved in outdoor activities, and he sustained an L1 fracture. And you can see the back of that vertebra, back of this vertebra, the back of that vertebra is gone posteriorly into the spinal canal. And look at how that vertebra has been compressed down, right? This patient had partial cord injury, did have some function, but still weak. You can see on the MRI scan, there is significant compression on the spinal cord with swelling of the spinal cord. So you can see that there is a significant impact of the spinal cord. And on the horizontal cuts, you can see there is hardly any CSF left. So that is the spinal canal. That's all that is left because of the vertebra migrating backwards onto the spinal cord. And this patient had surgery from the side. So we come in from the side, take the rib down, go inside, take the vertebra out. You still see the shell of the vertebra, but the spinal cord is completely free. We reconstruct using a cage and screws and rods. So we just realign and stabilize after having decompressed the spinal cord. This is another example, a high-speed car accident, and you can see where the vertebra is lying. So that's 5, 4, 3, 2, 1. So that's L1. It's completely digging into the spinal canal, causing spinal cord injury, and patient had complete paraplegia. So unfortunately, the die was cast, the damage was done. So you're trying to prevent secondary injury. So all you're trying to do is realign. So again, you can see the damage to the spinal cord on that MRI scan. So all we did was we did posterior stabilization and fixation. Now the difference between this patient and the previous patient, because the previous patient had incomplete injury, it's not that made me do the anterior surgery, but that patient had progressive weakness. So they were weak, but they were getting weaker. So take the pressure of the spinal cord. The pressure is from the front. So you go from the front and take the pressure off. Whereas in this situation, or if somebody has got static neurology, one would just do a posterior stabilization alone, and that would suffice. Here's another example of a patient who presented, and there was this debate in A&E about what this fracture is, or is there a fracture or no. And and when you look at it, our trainee rightly pointed out, something's not right. Look at the alignment. There is a slight scoliosis, right? And if you look at this, so if you see the vertebra, so that these are the pedicles. So the two things that are staring at you, or the eyes, are the pedicles, and the nose is the spinous process. So you can see there is a break in the eyes. So something gives you a clue that something's going on, and that is L1, L2, right? So as I say, they had a CT. On the CT scan, you can see there is a fracture through the pedicle, and on the sagittals, you can see the fracture going through the spinous process into the pedicle, and there's a fracture at the spinous process. So this is more like a chance fracture. So this fracture is going through and through and through, right? And this can cause kyphosis and malalignment. So this was stabilized just from the back, because we're just trying to recreate the posterior tension band and realign the spine. Yeah. This is another example. A patient who fell off a reasonable height. He was a construction worker, and he was neurologically complete, and we just stabilized that, just to realign the spine so that nursing's better and prevent further neurological issues, although there was not much left in neurologically. This is an osteoporotic case where there's a patient who's got osteoporosis, which, as you can see, is being treated with a brace, which is what we would normally do, all right? And 4 weeks after the osteoporotic fracture was picked up, and this is a retired person who had problems, who was known to have osteoporosis, has got previous osteoporotic fractures lower down. This was the new one at this level, and we were treating it non-operatively, and they started having problems 4 weeks down the line with neurological problems. So you can see why they were getting neurological issues where there is compression on the spinal cord. So you can see the old fracture, you can see the new fracture, you can see the edema or the white area, white signal, which suggests that is new. Look at these old fractures, there's not much signal in them, and that's called spinal cord compression. And because there were multiple osteoporotic fractures, we had to go long. We couldn't fix all the osteoporotic levels, but we did supplement the screws with cement or use this bone substitute, and realign the spine and decompress the spinal cord. That's one way to look at it. Now, this is an interesting case, and this is a gentleman who was at home. He was shaving, and he just lost balance, fell backwards, hit his head against a shower cubicle, comes into A&E, walks into A&E virtually, complaining of neck pain, right? His X-ray would, if I show you what is wrong, there's definitely something going on in the front. So you see the anterior longitudinal ligament seems to be calcified. The bones look osteoporotic. At this segment, right, there is something going on. So that is C2, C3, C4, C5, C6, C7. So between C5 and C6 and C7, something's going on. We're not sure. Not much soft tissue swelling. Giles, can you put the poll up, please?
Yep.
So what do people think? Do we think it is, we should treat this with a cervical orthosis, halo, operate, or do nothing?
Okay, so those are coming in now. So we're up to about 35%. Keep it on for a few more seconds. Brilliant. So I'll just stop that there and share the results. So you can see that the biggest group, 45%, was saying a cervical orthosis. This third would probably be halo with 19%. The second one would be 28% saying surgery, and 9% would do nothing.
Okay, so most would treat this non-operatively. Can I just go back to the X-ray? All right. As suggested earlier, unless proven otherwise, any injury that we pick up on any fracture, I know this is not very clear, but that's why I wanted to highlight there's something going on there. Any fracture in the cervical spine would be unstable. More than that, actually, this patient has got ankylosing spondylitis. That's what I was trying to highlight, right? And that would make you suspicious of what's going on. So just a word of caution, and that's what happened to this guy. He was put into an orthosis, and you can see what's happened. So you can see the ankylosis, the anterior longitudinal ligament is calcified. when the orthosis were applied, normally the neck would be forwards because of the kyphosis. The neck was lifted up. You can see it is causing hyperextension at the level of the fracture, which is not what we want. The actual trajectory of the neck should have been like this, right? So the actual trajectory, so it should have been in a neutral position for the patient, not in the normal position, which would be for most of us, right? And that's the message I want to. So putting orthosis on, putting collars on, be careful, be mindful. If the patients have got any ankylosis or anything, put them in their alignment rather than in an alignment which we think would be normal for them, right? Thank you.
Brilliant. Thank you very much. So we have quite a few questions, as long as you don't mind me asking those, Mr. Ahuja.
Yep.
A question from Nicola Rispoli. How would you differentiate between a rotation dislocation and a spondylolisthesis?
Okay. It depends where the break is and how it's how the listhesis is going on. Now, in a way, if it is a bilateral, then it'll be a uniform listhesis. Whereas if it is unilateral, I'm talking about the cervical spine, it'll be associated with rotation. So it could just be a flexion, distraction injury, which will give rise to a listhesis, right? But that's a vector that's going from back to front. Or you could have a rotary force along with that as well, which could give rise to a unifacet dislocation. So that's how you would pick up. But either way, that's quite an extreme injury. These are flexion distraction injuries, which are quite significant.
And one thing sort of going on from that question I wanted to ask, something that's come up in some of the previous webinars is that some of the speakers have been saying about video footage of injuries, for example. Is that something that's useful? If people have video of their injury, would you look at that, and is that useful?
No doubt it is useful. Any bit of information useful. Like, right from the paramedic who's picked up the patient and they're feeding into us as to how the position of the neck was, what was happening, or the position of the patient is helpful. There's no doubt. All those things are useful bits of information. But sometimes we're not that lucky, or most of the time we're not that lucky to have all that. If we have all that, it helps to put the jigsaw together, right? But then otherwise you've got to rely on the imaging that you have in front of you. Right? Even the patients may not have good memory as to exactly what happened, because that impact is so quick and sudden that you can't remember it, can you?
Mm-hmm. Okay. Mohammed Shafi asked if there's any role for steroid injection in an acute spinal cord injury.
Simple answer, no. In the UK, we don't give steroids for spinal cord injury. There's no evidence for it.
Right. Okay. And Jennifer Wilson asked, it's sort of a two-part this, but in clinical exam as a therapist, how clinically can we diagnose a facet injury or disc injury, for example? Is there a way to do that clinically, or is it just a case of tertiary referral?
No. Clinically, there is a lot of room to maneuver and assess. It all depends on the patient's symptoms, isn't it? Yes, of course, if you have any trauma, you will have pain. But pain that would not fit with what you would expect to see. So if I twist my ankle and I've got a sprain and I keep yelling all the time, every time I weight bear, we've all twisted our ankles to a degree, sometime or the other. And you can manage. But if pain persists, then you may have pulled a piece of bone with it, or you may have done something else. So you got to go with your clinical impression of what you think it is. And then, of course, you've got the investigations to help you. So you've got your x-rays, your CT, your MR, and it'll be useful. And if you're not completely convinced, speak to your friendly surgeon. If you're not convinced, speak to your friendly radiologist. It'll be useful. We all work together on that.
Okay. And Agostinho Faletra asked, on average, what percentage of patients do you treat conservatively?
Oh, that's a difficult one. I was going to look at that data. I'm really sorry. Because I'll tell you why. I was going to, because last year we presented all our data to the major trauma network. And I would say of all the tertiary referrals that we get, because we do get quite a lot, vast majority are non-operative. I would say nearly half to 2/3, because it is slightly skewed, because there's a big chunk of pec fractures in the elderly, which skews the data quite a lot. But if we talk about high energy impact, then, you know, there are not that many who would be treated non-operatively. Like, you know, then perhaps you would be 50-50 or 55-45 to that extent. But if we take everything, low energy, high energy, like, you know, a fair chunk are non-operative.
Okay. And a question just to clarify what you meant by a soft collar for peg fractures. Is that a Miami J or equivalent? And that's from Gillian Taus.
No, I just mean a neck warmer.
Okay,
Sorry.
so
And
a
that
foam
too,
collar.
it's for comfort. It is just for comfort. And even that, if the patient finds it too difficult to cope with, in our unit over the years, we just want to make the patient as comfortable as they are.
Okay. And question from Ashley Fowler. Do the stabilization procedures, including fixation with screws and cages, have a detrimental effect on local muscle function post-op, or disturb the deep muscle attachments at their insertions, for example?
You have to access through by reflecting the muscle of the bone. Of course, it will have an impact on the muscle. But the flip side is you got instability. You got to stabilize. Some people may do it minimally invasive, but even then that would lead to scarring. And on the other hand, once you fix that segment's not moving. So those segmental muscles in that segment may not be moving that, but would be contributing to the rest. Yes, there is, but you've got to weigh up the risks and benefits.
Okay. A question from Hugh Mallison. We're being asked to fit orthoses to patients with unstable fractures perhaps more often than we used to. Is this because treatments has changed, or have braces improved? What are your thoughts on that?
Oh, no, there's no doubt there's evolution in bracing. Bracing has improved quite a lot. There's evolution in our understanding of fractures as well. I'll give you a good example. You know, the burst fracture I showed you, which was treated non-operatively, and I showed you the CT scan. At 3 months, there was a time when we used to fix those all the time. And we looked at our data in 2004, 2005, and we saw that it wasn't making any difference. You know, we were trying to fix them to recreate the thoracolumbar alignment. As I said, that is a relatively straight segment, and kyphosis can cause issues there because it affects the overall alignment. But we found it when you stabilize and you correct, they were still kyphosing to an extent. And there was no correlation between the angle of kyphosis and the pain the patients were receiving after surgery. So, you know, those fractures we don't treat anymore, right? We don't operate usually. So things have changed from that as well, from our understanding, you know, looking at our own data, looking at data from elsewhere, everything, you're putting all that together. So yes, some things have changed from that point of view, and some things have changed from a surgical point of view, where more surgery is being done for certain cases and less for certain cases.
Okay. All right, good to know. Perhaps one last question. There's still a few outstanding, but I think this one's good in the current situation. Question from Cara Chandler. Is COVID continuing to interfere with treatment for patients, post-surgery, outpatient and rehab-wise? I know we were talking about this prior to starting this webinar.
Okay, no, I think there are different aspects to this question. I'll tell you how it was when the lockdown was about to come in. Everybody was gearing up and preparing up to treat fractures like it was done in the 1910s, 1920s, 1930s. I'm being pretty serious about that. It's a very serious call. Like, you know, people were looking at Charnley's book from the 60s, how to treat fractures non-operatively. But I think the thing that has helped a lot was the high velocity injuries reduced because the traffic's gone down, right? So effectively, we weren't being overburdened with that many number of cases. So we've continued to operate where, like we would normally. It hasn't changed our management plan. Of course, we've taken all precautions as one would normally take. So in a way, that hasn't changed, which is like, you know, I'm looking back at it now compared to how I was perceiving it about say 2 months ago when the lockdown was coming in, and I was thinking, oh, are we going to be treating everybody in a different fashion? But we haven't, and which is good because we've dealt with the cases as they should be, as up to date as possible and done everything as they should be, which is good.
Okay.
And I don't think the rehab, because the rehabs, certain things have gone virtual, certain things have still been face-to-face. Our rehab clinicians have been providing us in-reach service, so that stayed the same as well, either virtual or face-to-face.
Okay, brilliant. Thank you very much, Mr. Ahuja. Really, really interesting. A lot of really great comments. Thank you very much for that. What I'd like to do to follow on from the last sort of COVID question is really one last poll, because with these sessions, we'd like to evolve as the situation changes. So just from a timing perspective, when would you feel further webinars would be better to have? So perhaps as restrictions start to ease, would you prefer them between 9 and 10, 12 and 2, 3 and 5, perhaps an early morning session or an evening session? So we'll collect those and then we'll look at those. It just helps to inform us for the later sessions. So I'll stop that one there. Thank you very much. So really remains for me just to say thank you to Mr. Sashin Ahuja. Brilliant talk, really, really interesting. Thank you very much for joining us. My colleague Stuart has actually put a link for the next session in the chat function. So if you want to register for that one, there will be a follow-up email with that in, but it's in the chat function should you want to do that now. And it's with Dr. Claire Minshall, looking at rehabilitating patients post-lockdown, addressing the neuromuscular consequences. So Dr. Claire is a rehabilitation and conditioning specialist. So a really fascinating talk we hope to have next week. Do also note that the timing may or may not change, just because of easing of conditions and that sort of thing. So very much a fluid situation, but we will let you know if there are any changes to that. Thank you very much for joining us. Thanks again to Mr. Ahuja, and we will see you next week.
Thank you.